This is to introduce a virtual journal club. I have created this journal club as a mechanism of communicating with the other members of the group. I thought it best that we start with a case presentation with a discussion of the various different disease states that were revealed in an ordinary patient visit. I've actually called this case the case of the itchy patient with abnormal liver function and an elevated cholesterol. The opinions expressed are those solely of this author, and I have no conflicts of interest. I'd like to make a point. Skin disease can be deeper than skin. Urticaria is often difficult to evaluate, despite being a relatively common condition. In this patient with urticaria, it also revealed the fact that she had non-alcoholic liver disease, a disease that's not uncommon in our patient population, and an associated state, familial hypercholesterolemia, and its consequences are discussed. Let's go on with the case. The patient is a 61-year-old white female who was first seen by internal medicine with a complaint that she had severe itching. She had been treated for a similar complaint at the Kaiser Permanente Medical Group, where she had been seen both by internal medicine and dermatology. Relevant results from Kaiser before she was seen in our clinic are noted below. The slide may not be fully visible, and I apologize for it. However, I try to summarize the salient points in this slide. The patient had evidence of liver function abnormalities with elevations in the GGTP level. She also had normal complement levels, a normal protein, and a serum protein electrophoresis done on 2 occasions in 2016 and 2017 were unremarkable. She was studied further for liver disease and had a negative mitochondrial antibody, had a nuclear antibody that was negative. She had normal TSH levels and vitamin D levels, which were also normal. Noted also in Kaiser were rather significantly abnormal cholesterol levels. In 2006, the patient had a total cholesterol of 252 and an LDL level of 182. Just prior to being seen in our clinic, our cholesterol level recorded in Kaiser was 254 with an LDL level of 148. Evaluated also at Kaiser were various hepatitis components, and she was negative for hepatitis B surface antigen, hepatitis B core antibody, hepatitis C antibody, period. She had also been referred to dermatology, where an allergy screen showed that she had no significant allergies to a multiplicity of allergens seen normally, and a tissue biopsy of skin showed evidence of focal excoriation with rare eosinophils but chronic inflammation. The patient later transferred her care to Sutter, and I had occasion to see her. Her history also revealed the fact that she had a latex allergy, period. Her mother had died of esophageal cancer. She had no knowledge of her father. Her brother had suffered a thrombotic stroke, and her son was being treated for significantly elevated lipids. The patient was married, worked in a clerical position, did not smoke or use illicit drugs. She drank wine with meals. On evaluation, She had evidence of a moderately elevated diastolic pressure with no fundoscopic abnormalities. No neck masses were evident. Cardiac examination was unremarkable, and no bruits were audible over distal vessels. Diffuse punctate lesions were present over the skin. Some were bleeding as a result of itching and scratching. Our suspicions of a drug rash led to the discontinuation of all earlier medications, which included atorvastatin. A referral was made to dermatology and lab ordered. The initial lab obtained showed a CBC demonstrating a white count of 6600, which was characterized by significant eosinophilia. 16% of eosinophils were seen in a peripheral smear. She was mildly hypokalemic with a potassium of 3.1, with otherwise normal electrolytes and normal kidney function. There was evidence of an elevated total protein level with a total protein of 8.3 grams percent. Her liver function test showed elevation in both AST and ALT levels. Alkaline phosphatase and bilirubin were normal. Cholesterol obtained initially on being seen at Sutter noted a total cholesterol of 269, a triglycerides of 192, an LDL level of 167, and a HDL level of 64. She was referred to dermatology. Photographs, which may not present very well, showed that she had diffuse erythema and rashes. Photographs were taken by dermatology. Once again, a skin biopsy was performed, and the skin biopsy showed evidence of findings compatible with a perforating disorder. Perforating dermatoses represent a group of skin disorders characterized by perforation or elimination of dermal connective tissue through the epidermis. There are multiple types based on the type of epidermal destruction. It's believed that this is a mild disease, rarely problematic, which resolves spontaneously. No significant trials have been conducted, and it's believed that methotrexate helped the reduction in the development of new lesions over a 10-month period. Treatment failures, however, were noted with oral vitamin A, prednisone, oral antibiotics, and topical keratolytics. On a dermatology follow-up, where she was treated with steroids, it was felt that she had done better. The patient was told to come back on repeated follow-up, and dermatology concluded that the itching was associated with Lipitor, as the patient's itching had improved with the treatment with topical steroids. Soon after, we received an MHO message which stated, "I have severe itching again. Could it be for my new medication? I was hoping it would get better, but I'm not getting any relief. Thank you." A dermatology had ordered an IgE level, and the report came back that it was greater than 5,000 units per liter. She was then referred to allergy. Patch testing was negative, and allergy conclusions included the fact that they believed that she had a topical effect of polyester fumes, an allergic dermatitis due to other chemical products, urticaria, and a patchy skin. Another MHO message, once again directed to the primary care physician, noted, "For the past several months, I haven't had an appetite. I feel nauseous a lot. Do you think one of my medications is causing this?" She had, in the interim, also been evaluated by a local community dermatologist. A treatment was started with Xolair or Melizab for chronic idiopathic urticaria. The patient did respond to the fact that she had a significant reduction in symptoms, though she didn't describe total reduction in symptoms. She was also referred to Stanford. At Stanford, once again, the diagnosis of chronic idiopathic urticaria was made and Xolair continued. Chronic idiopathic urticaria or chronic spontaneous urticaria can be characterized by a situation where the patient has hives that recur for 6 weeks or longer. The hives are often associated with angioedema. Chronic spontaneous urticaria is usually an urticaria predominant phenotype in more than half the patients. A mixture of urticaria and angioedema is seen in another 40%, while in another 10%, angioedema is a primary presentation. The term spontaneous is included to differentiate chronic spontaneous urticaria from several forms of physical urticaria. These are urticaria that are triggered by physical stimuli such as heat, cold, or pressure, water, vibration, and sunlight. A physical urticaria is called inducible urticaria. Chronic spontaneous urticaria is thought to involve up to 1% of the general population and is similar to its prevalence in other countries. Both children and adults develop chronic spontaneous urticaria, though it's more common in adults. As in this patient, women are affected twice as often as men, and the condition typically begins in the 3rd to the 5th decade of life. The clinical manifestations of chronic spontaneous urticaria are usually limited to the skin, though some patients report other accompanying symptoms. Urticarial lesions, also called hives or wheals, have 3 typical features. They include a central swelling with surrounding erythema and an itching sensation, a fleeting time course that usually lasts for between 30 minutes to 24 hours. Angioedema, if present, is defined as episodic submucosal or subcutaneous swelling that is usually asymmetric in distribution, affects non-dependent parts of the body such as lips, cheeks, periorbital areas of the face, extremities, and genital. It usually resolves over 1 to 3 days. Affected areas have a slight degree of painfulness and tingling rather than pruritus. The diagnosis of spontaneous urticaria is made in a patient with characteristic skin lesions of urticaria and angioedema, which appear and resolve repeatedly over periods of 6 weeks or longer. There are no other signs of systemic disease, and laboratory evaluation is usually normal. Laboratory tests frequently show significant eosinophilia, and its presence should prompt search for atopic conditions and parasitic disorders. If there are elevations in CRP and SED rate, consideration for other infectious diseases, autoimmune disorders, and malignancies should be considered. Further tests in that instance will include an ANA, hepatitis screens, cryoglobulin, total hemolytic component, serum protein electrophoresis, and thyroid stimulating hormone. Chronic spontaneous urticaria is rarely a sign of an underlying disorder, and when it is, other systemic symptoms are usually present. This condition is rarely permanent, and it persists usually for less than a year. Should it persist for longer than a year, an extended course can be anticipated. Chronic spontaneous urticaria, despite the hives and urticaria, is not a systemic allergic reaction. It is only limited to skin and mucosal areas, and internal organs are not involved. The treatment of chronic spontaneous urticaria is initially with second-generation antihistamines, which would include cetirizine or levocetirizine. If these are overly sedating, H2 blocking antihistamines can be used, such as ranitidine, famotidine, and cimetidine. Flares may be treated with short doses of high-dose prednisone. Recent therapies of benefit are the monoclonal antibody omalizumab or Xolair, which targets the IgE pathway. Since this is an expensive medication, a specialty referral is recommended for insurance approval. Most recently, dapsone, which was also used in leprosy, has been found to have some efficacy in recalcitrant cases. If there is renal insufficiency, sulfasalazine may be used instead. Once again, a specialty referral is necessary. The use of hydroxyzine and doxepin as therapeutic adjuncts are often helpful. With the control of the patient's urticaria, we had to address the other primary care problems. These included hyperlipidemia and abnormal liver function. Presented below were her lab values once atorvastatin was discontinued. Her alkaline phosphatase now was elevated, where it had been normal at the start. Her AST and ALT had risen about threefold. Her cholesterol was now 344, with an LDL cholesterol of 247 and an HDL cholesterol of 60, which remained unchanged. Once again, atorvastatin was started. Atorvastatin was efficacious in the reduction of her cholesterol. After 3 months of atorvastatin therapy, lipids had improved, the total cholesterol having fallen almost 100 points, and the LDL similarly had similar falls. However, liver function tests were essentially unchanged. We were then faced with another dilemma. Were the lipids responsible for her liver abnormalities, or could she have a component of statin hepatotoxicity? Once again, atorvastatin was discontinued and investigations restarted. An ultrasound of the abdomen for evaluation of abnormal liver function tests showed that the patient had evidence of hepatomegaly, and the radiologist believed that she had hepatic steatosis. The discontinuation of atorvastatin, as noted earlier, had not improved our liver function, and the lipids had risen once again. Evaluation for primary liver disease showed no evidence of hepatitis A antibody, hepatitis B core antibody, or hepatitis B surface antigen, or hepatitis C antibody. The TSH were normal. Earlier evaluations in Kaiser and at the allergist had shown no evidence of any autoimmune disorder. She did drink wine with meals. It is important that the National Institute of Alcoholism defines excessive alcohol intake as being approximately 21 drinks a week in a male and 14 in a female. The patient's alcoholic consumption was nowhere near this. Thus, we were led to believe that the patient had a hyperlipidemia and the abnormal liver function were associated with non-alcoholic fatty liver disease with associated early fibrosis. A fibro test performed in our lab showed that she had an elevated fibrosis score at F2, suggesting early bridging, which will be discussed further. Her inflammatory activity was also elevated. Our tests done at this time noted the fact that she had elevated gamma glutamyl transpeptidase levels and ALT levels. A non-alcoholic fatty liver disease is defined as steatosis seen on imaging or histology without significant ethanol use or the use of steatogenic medications. Two types are recognized. Non-alcoholic fatty liver, where there is greater than 5% hepatic steatosis without evidence of hepatocellular injury, as in the form of hepatocyte ballooning and often elevated liver function tests. A more severe form of non-alcoholic fatty liver disease is non-alcoholic steatohepatitis, the NASH syndrome. Here, once again, there's greater than 5% hepatic steatosis. However, there's inflammation, hepatocyte ballooning, and frequently the beginning of fibrosis. Non-alcoholic fatty liver disease has several stages. The first stage is just plain steatosis. Steatosis itself is believed to be present in 25 to 30% of the general population. About 6% of the general population infected with the disease develop steatohepatitis, and of this 6%, 15 to 20% of NASH cases proceed to develop cirrhosis, which eventually leads to either death, significant morbidity, or terminates in hepatic transplantation. It's believed that there is a genetic predisposition to this disease, and various genes have been identified. Some of these are phenotypic, but the genes are responsible for an impairment of lipid transport and are related usually to more advanced forms of the disease. Non-alcoholic fatty liver disease is rapidly becoming the major cause for hepatic transplantation. The number one indication for hepatic transplantation in patients under 50 years old is the NASH syndrome. The NASH syndrome today is more common in this age group than is hepatitis C infections. Characterizing a non-alcoholic fatty liver disease are elevated liver chemistries. There's considerable debate as to what a level of ALT and other elevation is associated with the development of non-alcoholic fatty liver disease. The upper limit of normal of ALT is 30 in males and 19 in females. Our electronic records, EPIC, has a normal range of 1 to 45 international units, and eClinicalWorks normal range is 13 to 69. While many individuals have non-alcoholic fatty liver disease, which is discovered by imaging, which shows steatosis, the patients may frequently have normal liver chemistries. The presence, however, of abnormal liver chemistries signals a higher likelihood for the non-alcoholic steatohepatitis syndrome with or without the development of fibrosis. Evaluation of non-alcoholic fatty liver disease and associated abnormal liver chemistries should indulge a history of significant alcohol use, which should be ruled out. Medications such as methotrexate, tamoxifen, anabolic steroids, and amiodarone may also alter liver chemistries. Hepatitis A, hepatitis B, and hepatitis C status should be evaluated. Autoimmune hepatitis should be ruled out by evaluation of ANA, anti-smooth muscle antibodies, and IgG levels. Hemochromatosis is often evaluated from serum ions and ion binding capacities with associated ferritins. If there's a suspicion of Wilson's disease or familial neurologic syndromes, cellular plasmin levels should be obtained. Alpha-1 antitrypsin deficiency is frequently associated as a genotypic abnormality, and evaluation should include imaging, which should include liver ultrasound, a CT, an MRI, and MR elastography. What do we do if we see fatty liver on imaging? The first thing we check for is abnormal chemistries. If abnormal chemistries are available, we have to work the patient up as a case of non-alcoholic fatty liver disease. If abnormal chemistries are not present and the patient has evidence of a metabolic syndrome with increased BMI, glucose intolerance, and the other features of metabolic syndrome, once again, the patient should be evaluated as non-alcoholic fatty liver disease. If none of these are present, one should inquire further as to a history of ethanol use and other hepatotoxic medications. Non-alcoholic fatty liver disease is commonly associated with obesity, type 2 diabetes, dyslipidemias, metabolic syndrome, polycystic ovarian disease. Less commonly associated with hypothyroidism, obstructive sleep apnea, hypogonadism, hypopituitarism, post-pancreatic or duodenal resections, and psoriasis. Non-alcoholic fatty liver disease is discriminated on and its severity based on liver biopsy or surrogate tests which disclose the presence of fibrosis expressed as F0, F1 as fibrosis with sinusoidal presence, F2 when this is also accompanied by periportal fibrosis, F3 when there is bridging fibrosis, and F4 which is fully developed fibrosis. The stage of fibrosis is the only histologic feature that can be independently associated with either death or liver transplantation. In the first stage of fibrosis, there's approximately a twofold increase of death and morbidity. In stage 2 fibrosis, it rises threefold In stage 4 in stage 3 fibrosis, it rises fourfold, and at stage 4 fibrosis or cirrhosis, there's an 11-fold increase in mortality and morbidity associated with the disease. A diabetes mellitus adds approximately a 50% increased risk, while smoking confers approximately twice the increased risk. Statin use is not associated with an increased risk of non-alcoholic fatty liver disease or associated with death or hepatic transplantation. Since liver biopsy and other expensive imaging techniques are not easily available, various surrogate markers making use of various algorithms which include age, BMI, hyperglycemia, platelet count, albumin, AST and ALT ratios are utilized, and there are various scoring systems. Available in our lab and through Quest is the FibroTest, which was used in this patient. There's an online resource and an app that can be downloaded to estimate a non-alcoholic fatty liver disease fibrosis score on a calculator if the various components such as age, BMI, the presence or absence of diabetes, AST, ALT, and platelet and albumin are available. More recently, a non-alcoholic fatty liver disease is being evaluated by a FibroScan, which is actually a vibration-controlled transient elastogram. It's not available in our community. The presence of MRI, as also MR elastography, are now being increasingly used. Does liver biopsy have a role? The role of liver biopsy is essentially there when the diagnosis of NASH by the use of various surrogates is insufficient, or when we need to initiate drug therapy or totally assess prognosis. It may be necessary if fibrosis cannot be staged by imaging or other tests. It may also be necessary to rule out concomitant liver disease, including autoimmune liver disease, Wilson's disease, iron overload syndromes. In patients with suspected non-alcoholic fatty liver disease, in which there's hepatic steatosis on imaging and elevation of serum ALT levels, one must first evaluate alcohol consumption and exclude alternate causes of ALT. However, once non-alcoholic fatty liver disease is confirmed, there are several profiles. On the far left of the slide, the low-risk profile includes one with a BMI of 29.9 or less, an age of 40 years or less, no history of type 2 diabetes or metabolic syndrome, and a low FibroTest or FibroScan scores. An intermediate risk profile would involve a BMI in excess of 29 and an age greater than 40 with features of the metabolic syndrome and evidence of early fibrosis on various testing. High-risk profile includes AST levels that are elevated with platelets less than 150,000 and markedly elevated surrogate markers for fibrosis. In the low-risk profile, it would be worthwhile following, reassessing, and treating with methods that are described. In the intermediate risk profile, a consideration for liver biopsy should be addressed. In the high risk profile, liver biopsy or confirmatory testing by a fibroscan or magnetic resonance elastography is important. How do we essentially treat non-alcoholic fatty liver disease? At the base of treatment is weight loss. It's been shown a weight loss of 10% is enough to induce regression of fibrosis in approximately 45% of patients. Lesser amounts of weight loss are also associated with the resolution of NASH syndrome in 64 to 90% of patients. And even a weight loss of 5% would be able to decrease 40 to 100% of ballooning changes in patients. Weight loss of 3% can in fact reduce steatosis in greater than 50% of patients. Thus, the most important treatment that we have from all randomized studies in this condition is weight loss. At this time, there are no FDA-approved therapies for non-alcoholic fatty liver disease or the NASH syndrome. Various new trials have utilized vitamin E and pioglitazone or Actos in the management of these, but have not had any definite results. Various new substances such as obeticholic acid and liraglutide are also being used, but no definite statement can be made of the efficacy. Clinical trials are yet in progress. Let's address familial hypercholesterolemia, which was also present in this patient. Once again, let's review her cholesterol levels. She had a cholesterol level of 345 and LDL levels markedly elevated through the year. The most recent cholesterol level earlier in August of 2019 was 309 with an LDL level of 220. Further, she had a son with severe lipid abnormalities and a brother who had atherosclerosis. Family hypercholesterolemia is a primary impairment of LDL clearance with an associated increased secretion of ApoB lipoprotein B particles. There is a decreased degradation of ApoB in the liver and increased production of ApoB containing lipoproteins into the circulation. There's also an increased LDL uptake by LDL receptor independent pathways, which drives increased synthesis of ApoB containing particles. There are now various algorithms which can be downloaded to your smart devices to evaluate a patient. Here is one of them, the Simon Broom diagnostic criteria for familial hypercholesterolemia. Included are the total cholesterol level, the LDL level, the presence or absence of tendon xanthomas in the patient, first degree relatives or secondary degree relatives, DNA based evidence of a functional LDR receptor, PCSK9 receptor, and ApoB mutation, a family history of premature coronary vascular events, a myocardial infarction under the age of 50 in second degree relatives, or less than 60 in first degree relatives. Family history of extremely high cholesterol, greater than 290 milligrams percent in adults in first to second degree relatives, or greater than 260 in a child or sibling less than 16 years old. Applying the Simon-Broom criteria to our patient, the patient satisfied the criteria and was described as having a probably high likelihood of familial hypercholesterolemia. Achilles tendinopathy is demonstrated in this patient with familial hypercholesterolemia. The Japanese criteria are more easy to understand and to implement. They include an LDL-C before treatment of greater than 180 milligrams percent, tendon xanthomas or nodular xanthomas of the skin, and a family history within the second degree relatives of familial hypercholesterolemia or premature coronary artery disease. Our patients meeting two items in this can be regarded as having familial hypercholesterolemia. Diagnostic testing is further being pursued with genetic testing for autosomal dominant mutations of the LDR receptor, as also a mutation for the ApoB lipoprotein receptor, and there are mutations now for the PCSK9 receptor. There's an app available for both iPad and iPhone created by the Familial Hypercholesterolemia Foundation, which one can download in their smart device, that provides some excellent information on the management and understanding of familial hypercholesterolemia. As stated, familial hypercholesterolemia is familial and family screening is critical. One can ask how familial hypercholesterolemia is inherited. Like many other genetic disorders, each child of a person with familial hypercholesterolemia has a 50% chance of inheriting the disorder. It is thus essential to screen parents, siblings, and children of patients diagnosed with familial hypercholesterolemia. At present, most people with familial hypercholesterolemia have variants of one of three genes: the LDR receptor gene, the ApoB lipoprotein gene, and the PCSK gene. Although at this stage there are over 2,000 known variants for familial hypercholesterolemia. Treatment for hypercholesterolemia involves the institution of high-dose statin therapy. High-dose statin therapy would involve atorvastatin in a dose of 40 to 80 milligrams or rosuvastatin in a dose of 20 to 40 milligrams. This can reduce LDL-C by greater than 50%. Moderate intensity statin therapy, as also low intensity statin therapy, is not very efficacious, but is included in this discussion as a means of advancing knowledge. Adjuncts to treatment include cholesterol absorption inhibitors. This would include Zetia or ezetimibe, which is available. It's unknown, based on the prior trials of ezetimibe and simvastatin, whether this would lead to any improved lifespan outcome in the treated patients, but it does lower cholesterol. Bile acid sequestrants, which bind bile acids in the gut and are characterized by cholestyramine, cholesterol, and cholcelavin or Welchol, can also be used. The PCSK9 inhibitors, which inhibit the PCSK pathway, are now recognized as probably the most efficacious way of treating familial hypercholesterolemia. They are injectable drugs, usually injected twice a month. The drugs act by disabling the enzyme PCSK, which allows LDL cholesterol to be removed from the blood by a normal liver clearance process. There are two available, Praluent and Repatha. Both of them are expensive, and one can anticipate a significant resistance from the insurers to pay for them. One would have to document extensively the presence and the evidence for the presence of familial hypercholesterolemia. Advanced treatment for familial hypercholesterolemia includes weekly lipoprotein apheresis, which costs approximately $70,000 a year, and there are lipoprotein apheresis centers in the area. If one consults the app from the Familial Hypercholesterolemia Foundation, one can identify these centers. Lomitamide is a triglyceride transfer protein, essentially thought to have a role in the management of homozygous familial hypercholesterolemia. However, the cost of this medication is also $70,000 approximately a year. Liver transplantation is another treatment for this disorder, as the new liver does not have the FH causing genes, but it's generally reserved for very young patients with advanced atherosclerosis and no other treatment options. In conclusion, a patient rarely has a single problem. Our close attention to all problems is necessary. History taking by medical assistants may save time, but we'll miss these problems. Every problem does not require a specialty consult, and primary care must train those interested to manage chronic care. Thank you for your time. I will try to make this a feature available to all the members of the group. I ask for your cooperation and your criticism. I realize that this presentation may be rather crude and would welcome your opinions. You could email me at the email address detailed below. Once again, thank you and good day.